Welcome to today's webinar of the
Good
International
morning.
Eosinophil Society. Can you show the next slide, please? Next slide, please. So today's webinar is focusing on eosinophilic airway disease, and we have a truly prestigious lineup. This webinar is supported by Regeneron and Sanofi, who we extend a warm thanks to. As many of you know, novel therapeutic agents targeting different compounds of the type 2 inflammatory response are increasingly becoming available and are very helpful in controlling various diseases. Collaborations between scientists and industry has become essential for many reasons that extend way beyond the classical interactions that have existed for many years and that are mainly related to the clinical trial development. Clearly now, collecting data and blood and tissue samples from subjects receiving these treatments will accelerate our understanding of the complexity of eosinophils and diseases where they are found at different levels. Next slide, please. So the International Eosinophil Society has a series of missions, including education, and these webinars are integrated perfectly in our mission statement, which you can see here. And if you want to know more about our society, you can visit the society website, which is shown on the lower left-hand corner of this slide. Next slide, please. Here are a series of housekeeping messages. If you want to ask questions during the webinar, you can enter them into the question and answer functionality of Zoom. And at the end of each individual talk, our moderator will put these questions towards the speaker who will answer them for you. Everyone will be muted, so you will not be able to ask the questions yourselves, and the chat feature is disabled, so please use the question and answer feature. The webinar is being recorded, so if you wish to listen to it another time, or if you want to eventually send the link to one of your colleagues, this link will be posted on the IES website. And there are also recordings of all the prior webinars that have taken place up until now. We have a new feature, which is the closed captioning feature, and you can enable this feature if you press on the little button with 2 C's. The captions will be shown in English only. Next slide, please. So I would like to introduce our moderator, who was Nives Zimmermann, who works at the University of Cincinnati College of Medicine in the Department of Pathology. And I'm very happy to have her here today to moderate this session and to introduce today's prestigious faculty. Thank you, Nives.
Good morning or good afternoon, everyone, and welcome to our webinar today. I'm very happy to serve as the moderator, and we'll go ahead and get started with our first speaker today. This is Dr. Busse, who is a professor of allergy immunology at the University of Wisconsin School of Medicine. Has long-standing research interest in eosinophils and asthma, and has a lot of accomplishments and leadership positions in the Quad AI Advisory Council of the NHLBI, and we know him also as an editor of JACI and American Journal of Respiratory and Critical Care Medicine. But today he's going to speak to us about his research and specifically what do eosinophils and IL-5 contribute to asthma exacerbations. So Dr. Busse, please take the.
Thank you. Okay, great. Thank you very much. Can you hear me and see the slides?
Yes, perfect.
Yes, we can.
Okay, great. So what I'm going to be talking about this morning is what do eosinophils and IL-5 contribute to asthma exacerbations? This is a sculpture of an eosinophil, which was commissioned about 30 years ago. It's an artist view of the eosinophil bilobe, artistic granules in there. And again, sort of indicates my level of interest with the eosinophils. So these are my disclosures, none of which should have an impact on what I'm going to be saying. So the background and question of interest is, what are the rules for eosinophils and IL-5 in asthma exacerbations? And I think we really have evidence to indicate that they are playing a significant role. And if you look at the data published by David Price a number of years ago, as peripheral blood eosinophils increase, the risk for asthma exacerbations also increases, indicating that they're in the peripheral circulation, a risk factor for exacerbations. Secondly, looking at data from Sebastian Johnson, David Jackson, and others, there are data indicating that when rhinoviruses provoke an episode of asthma, IL-5 and eosinophils are playing a role in this process. So when in these experimental rhinovirus infections, rhinovirus infects the epithelium, generates the alarmins, including IL-33, which then activate lymphocytes, ILC2 cells, and they generate increased concentrations of IL-5 and increased levels of eosinophils. In addition to that, when rhinoviruses interact with neutrophils, they lead to neptosis, release of double-stranded DNA, which then act on T2 lymphocytes, generating IL-5, increasing the production of eosinophils, inflammation increases, and exacerbations occur. So eosinophils, IL-5, are shown to be contributing factors or associated factors with asthma exacerbations. So how does targeting IL-5 and eosinophils affect asthma exacerbation? There have been a lot of studies with anti-IL-5, anti-IL-5 receptor antibodies indicating that they are effective blockers of asthma exacerbations. And this is one of the earlier studies by Hector Ortega 8 years ago. And what his data show, and they really are confirmatory of what had been known in adults who have eosinophilic asthma, that in the presence of anti-IL-5, and this is mepolizumab, compared to placebo, there's a very significant, approximately 50% reduction in exacerbations. And if you look at the effect of blocking IL-5 on exacerbations, we know that it dramatically reduces blood eosinophils. It reduces exacerbations by 50%, not 100%, but by 50%. So the question is, what factors contribute to either the blockade or the absence of control of exacerbations when IL-5 is blocked? So to try to answer this study, this is a recent publication. First author is Dan Jackson, who's also on the line, and Matt Altman, who's a senior author on this paper, recently published in Lancet, and it was mepolizumab for urban children with exacerbation-prone eosinophilic asthma. It was conducted in the United States, and it's called the Muppets 2 study, which I'll define in the next slide. So this is the overall study design of Muppets 2, which is mechanisms underlying asthma exacerbations, prevented and persistent with immune-based therapy. And this is a system approach phase 2 trial. And again, in this study, we had children who were 6 to 17 years of age living in urban environments in the United States. They had difficult to control asthma. They had at least 2 severe exacerbations in the past year. And they also had evidence of T2 inflammation as indicated by eosinophil counts of greater than 150 cells per microliter. They were enrolled and underwent a run-in period of time, and they were either treated with mepolizumab along with guideline-based therapy or placebo and guideline-based therapy. And the primary outcome was the rate of asthma exacerbations. In addition to this, we did mechanistic studies, and I'll be talking about airway transcriptomics and how they may provide additional information and insight into the effect of IL-5 blockade and eosinophils on exacerbations. So here's the study population. Kids averaged about 10 years of age. They had some degree of airflow obstruction. Their FEV1 vital capacity is less than 80. They were almost 100% showing allergic sensitization. And looking at the eosinophil counts, their median levels were in those randomized to mepolizumab for 400 cells per microliter, 455 in the placebo group, and IgE was elevated. About 60% of them were at step 5 level care. And this is taking, fluticasone, salmeterol, 550 twice a day or an equivalent. And they had over 2 bursts of prednisone in the preceding year. So they're eosinophilic, they have severe, moderate to severe disease, and they have very frequent asthma exacerbations. The first thing we saw was the drop in peripheral blood eosinophils, as expected and has been seen in the adult population. Those children on placebo, their eosinophil counts remained basically unchanged during the study period of time. We also measured eosinophils in nasal secretions. And what you see with the placebo is a very constant level, and with those randomized to mepolizumab, there was a drop and this remained suppressed. So we have reductions, very dramatic, expected reductions in peripheral blood eosinophils, and also reductions in nasal eosinophils, which may be reflecting events that are occurring in the lower airway. Here are the primary outcomes. This is looking at asthma exacerbations in those children receiving mepolizumab and those on standard treatment or placebo. There's about a 27% reduction in the frequency of asthma exacerbations when the children are receiving mepolizumab. This is about half of what is seen in the adult population and previously published data in children or in adults. We also looked at the frequency of exacerbations over the year period of time. And as you can see, for those who were randomized to placebo, we had the seasonal variation for the September epidemic of asthma. And this is where mepolizumab had its primary effect. So asthma exacerbations were reduced. The reductions were primarily during the high time of exacerbations during the time children returned to school. So clinically, we had reduction in asthma exacerbations. If we look at the effect of either mepolizumab or placebo on lung function changes during exacerbations, remember, children on mepolizumab also had exacerbations. Lung functions were stable at baseline. They were stable when they had a cold, not in exacerbations. When they had an exacerbations, lung functions were significantly reduced. And then at the completion of the study, they were back to baseline. The pattern is very similar with placebos. Baseline lung functions during a cold without an exacerbation, lung functions are stable, but when an exacerbation occurred, the drop in lung function was very similar to those who had an exacerbation while on mepolizumab. So the next question we had was, what insights do transcriptomic analysis provide on exacerbations and the effects of mepolizumab? So here's what we did in this study. Again, this is the study design. Children randomized either mepolizumab or placebo, and we also obtained nasal lavages at randomization at 8 weeks and at completion of the trial, and also when they had a respiratory infection. And the question was, when the respiratory infection led to an exacerbation or not an exacerbation, what could we learn about the transcriptomic analyses? So here's a summary of the nasal gene module expression and exacerbation rates, and also in relationship to treatment. The module genes could be divided up into a number of large groups: eosinophil-related type 2 inflammation, mucosinoid metabolism, then eosinophils and epithelium, which would be activation and mucus secretion, and then epithelium-related genes. And we'll come back to this later. Here's the relationship between the nasal gene module expression at week 0, and then the number of exacerbations. Those randomized placebo, again, we find that type 2 inflammation, mucosinoid metabolism, and cytoplasmic proteins are related to the risk for exacerbations. This did not occur when they were on mepolizumab. If we look at activation and mucus secretion, these were not affected by mepolizumab, and they were increased in both those on placebo and also on mepolizumab. The part that was most interesting to us was the epithelium-associated gene modules. As you can see, when they received placebo, it was not associated with an exacerbation, but when they were receiving mepolizumab, it was. And this summarizes the treatment effects. On mepolizumab, the eosinophil type 2 inflammatory blockade is associated with a reduction or partial reduction in exacerbations. In contrast, when the children are receiving mepolizumab, this increased expression of these epithelial associated genes was also associated with an increased risk for asthma exacerbations. The other part that was interesting in both those on placebo and active treatment, their level of type 1 interferon expression was associated with a level of protection from exacerbations. Let me go into some greater detail in this regard. So this is looking at differences in type 2 inflammatory module expression and exacerbations when they were on mepolizumab or on placebo. This is looking at with a cold, both with mepolizumab and placebo. As you can see, the type 2 gene expression on standard treatment was higher than those who are on mepolizumab, indicating suppression of this type 2 module, IL-4, 5, and 13. With placebo, the values are higher than they were on mepolizumab, and they also increase during the exacerbation. So blocking the T2 pathway when an exacerbation occurs, these is associated with the reduction of these expressions, but not the suppression of the expression of these T2 inflammatory pathways. If in contrast, we look at epithelium-associated gene expression, we see a very different pattern compared to the blockade of type 2. Let me just focus your attention on TGF-beta SMAD3 cell differentiation. These are the individuals treated with mepolizumab during the cold, not an exacerbation, very similar between placebo and mepolizumab treatment. However, when an exacerbation occurs, what we are seeing is an increased expression of these epithelial-associated genes in children who are on mepolizumab. The same pattern is seen with IL-33. Again, baseline concentrations during a cold are very similar, but when an exacerbation occurs, the gene expression with mepolizumab and associated asthma exacerbations is increased. If we look at these in relationship to lung function changes, again, this is looking at epithelial expression of TGF-beta and SMAD. This is the fall in lung function on the vertical axis, and this is the module expression. The greater the module expression at the time of an exacerbation, the greater the fall in FEV1. So what can we say in conclusion? So what I've tried to do on this slide is look at the activation of inflammatory modules with exacerbations in relationship to treatment, T2 patterns of inflammation, and epithelial components of inflammation. With standard treatment, when an exacerbation occurs, these are increased, and we also see this increased in standard treatment. If the patients, in these cases, the children are treated with anti-IL-5, there is reduction in the T2 pathway and eosinophil pathway associated with exacerbations, but it is only partial. In contrast, when an exacerbation occurs in the presence of mepolizumab or IL-5 blockade, these patterns of inflammation from the epithelium are significantly enhanced and are associated with an exacerbation. So as far as protection from anti-IL-5, we have partial protection in type 2 inflammation and some of the eosinophil-associated pathways, but none with the effects when epithelial components are contributing to exacerbation. So this suggests that IL-5 and eosinophils do contribute to exacerbations, but there are other inflammatory pathways of inflammation, particularly the epithelial-derived, which also contribute to exacerbations. And the absence of protection from exacerbations by anti-IL-5 may reflect, at least in part, a reciprocal increase in epithelial cell-generated inflammatory responses. So this was, to us, provided us some novel insight into what role IL-5 and eosinophils are playing in asthma exacerbations. And again, these are primarily related to viral respiratory infections. These are complicated studies, and we've been very fortunate to have support through the NIH, through the Intercity Asthma Consortium, and now the PAUSE, which is childhood, asthma in urban settings. Again, we have a large number of investigators across the country. We have those of us at the University of Wisconsin, Matt O'Brien and his group at the Airway Institute and the University of Wisconsin, Washington. Also, the NIH was provided not only support, but also collaboration, and the Road Group doing this. And also very, very important were the study participants and also the coordinating staff at the various sites. So thank you very much for your attention. And if there are any questions, I will try to answer them.
Thank you very much, Dr. Busse. I will start with a few questions that are already in the Q&A box, but I will encourage other participants to continue asking questions in the Q&A box. So the question one of the questions is, what would you expect with Zoller in this atopic cohort regarding exacerbations?
That's a very good question. We don't have the answer there because we haven't done the studies. And again, I think the interesting thing that we have found with omalizumab is that one of its primary effects seems to be on antiviral activity. And we wonder if that would be the gene products that would be associated with this, that we might restore some of the interferon generating properties. And this may be why we're seeing the benefit with omalizumab in this situation. Again, until you do the study, as you know, it's speculation.
Thank you. Another question from Dr. Ackerman is this result suggests the eosinophils may have both regulatory and exacerbation roles?
Steve, this is an important question. And again, what we've also done, Steve, and didn't include the data on here because they're not completely analyzed. We did a CyTOF analysis of sputum eosinophils. And this gives us an idea of some of the subpopulations of eosinophils that are present in the airway and some of the subpopulations. And Steve, I think when we get these data done, these were done by Jeff Chop and his colleagues at Yale, Montgomery, and Gabby Wilson, and we try to better answer your question about some of the subpopulations and also the possibility that there may be inflammatory and other properties of eosinophils that are associated with exacerbation.
Thank you. I have a question from Dr. Rufus. Is there any evidence that eosinophils actually down-modulate epithelial-induced type 2 responses?
I don't know the answer to that as to whether or not they do. Again, prejudicially, one would think that they would be upregulating them. But again, until you try to dissect these situations, it's very difficult to answer that question. Dan or Matt, might you want to, speculate on that?
Sure, Bill. I can comment for a minute. Ultimately, that's a question we have a lot of interest in evaluating further. And one of the things we're trying to do in follow-up analyses is actually look at how these modules actually change with anti-IL-5 therapy. And for instance, the type 2 module that Bill described does tend to break apart when you treat with mepolizumab, and you start to see downregulation of downregulation of eosinophil signatures, but perhaps upregulation or maintenance of mast cell signatures, which may then ultimately alter responses in the epithelium. So it's a great question that we're looking forward to trying to answer as we move forward.
If I could just follow up on what Dan said. Matt, are you on the line? Did you want to add anything?
I think he's listening, but isn't a presenter, Bill. So okay, not sure that he can talk.
I think one of the eosinophil associated projects I mentioned was the eosinophil mucus gene product module. Again, that was not affected by treatment, and it also went up. And this would also include the possibility like of MUC5AC. So again, we find that this is really a complicated situation. And I think until we start to dissect it and knowing where these various biologics are acting, we really won't have an idea on the pathophysiology. And again, I think we just have the opportunity with the biologics not only being a therapeutic, but also being a probe for knocking out various pathways.
Thank you. One other question. So I think you mentioned that there was a difference in kids versus adults, and I was wondering if you could speculate on whether you have any insight on mechanistic reasons for that.
It's a good question. I'll make a comment, and Dan's a pediatrician, and I'll ask him to comment on this as well. I think if you look at some of the studies, and Gene Bleeker has published on the data with benralizumab, and looking at those who respond to benralizumab, that those who don't respond as well to benralizumab. And those who respond best to benralizumab are adults, late onset asthma, associated nasal polyposis, and sinusitis, more frequent asthma exacerbations. Again, it raises the possibility that there may be a different disease module, adult onset disease versus early onset disease, which may have a very different aspect in which 5 and eosinophils are playing a role. Dan, you want to expand on that?
Sure. Well, I agree with your comment, Bill, and in fact, early onset atopic asthma in the benralizumab data is associated with really a less robust response to therapy. And if you look at the small numbers of adolescents included in the anti-IL-5 studies previously, oftentimes the responses were less robust there as well. So I think this data is consistent with that. The drivers of exacerbations are also different across children and adults. As Bill alluded to, viruses are the most common driver of exacerbations in children, whereas in adults perhaps maybe trigger 50%. So it may be different triggers. There also may be aspects of our study population which included urban children living in environments exposed to high pollution and other irritants and things like that might help explain the altered responses. But I think it's very important to distinguish, and going back to that earlier omalizumab question, we see in contrast to our findings here, omalizumab actually tends to work better in children than it works in adults, which really suggests that the different components of type 2 inflammation may be having different response, or different contributions to response to therapy, and also different contributions to exacerbation across the ages.
Well, thank you very much. We have some additional questions, but we're running out of time, so I would encourage Dr. Busse if you could respond to them in the Q&A box later. But I would like to thank Dr. Busse for his presentation, as well as Dr. Jackson for answering some of the questions. And we will move on to the next presentation. So our next presentation is Dr. Chen from Tianjin University in China. His research focuses on the regulation of lung epithelial, stem, and progenitor cells and their role in respiratory inflammation and infection. He will talk to us today about crosstalk of eosinophils and airway epithelial progenitor cells in asthma. So with that, Dr. Chen.
Good morning, everyone. This is Huaiyong from Tianjin, China. I thank Dr. Rosenberger for the invitation. I'm going to share you with a little bit of work we just finished recently. That is a crosstalk between eosinophils and airway epithelial progenitor cells in asthma. Human lung organ is a very complicated organ with multiple tissues, including vasculature, smooth muscle, nerve, cartilage, lymphatic epithelium. Epithelium is an important part of two barriers in the lung homeostasis. Fourth, it works closely with vasculature to secure gas exchange, which is the main function of the lung. Second, it interacts with the lymphatic elements to build an immunological barrier. There are a dozen types of epithelial cells in the lung. Among them, I would like to mention two cells specifically. Club cells in the airways and alveolar type 2 cells. These two cells are abundant and versatile progenitor cells. They exhibit immunological regulation, antimicrobial secretion, antigen presentation, chemical detoxification, as well as active communication with immune cells. They can repel injured epithelium in the lung. For example, club cells can generate city cells and goblet cells. In the alveolar space, AT2 cells can generate AT1 cells, which is essential for gas exchanging. When these two cells are injured, basal cells and other stem cells can repopulate them. Many lung diseases are associated with the disruption of these two barriers. For example, lung cancer, COVID, idiopathic pulmonary fibrosis, asthma, chronic obstructive pulmonary disease. Full recovery of the lung is more than just the control of inflammation, which is the current focus of the medical practice. Injured epithelium is also a major source of inflammatory cytokines, so it must be repelled. But this issue has been ignored in the field for many years. Impact of immune cells on the lung epithelial regeneration is less studied. Asthma can be induced by so many allergens. There are two types of asthma, type 2 high and type 2 low. Type 2 high asthma is characterized by airway chronic inflammation, eosinophilia, mucus hyperplasia, etc. We personally adopt a mouse model of allergic inflammation to demonstrate that the pool of airway epithelial progenitor cells is diminished, suggesting insufficiency of epithelial repair, which may explain the persistence of epithelial injury in asthmatic lungs. DJ1 is encoded by Parkinsonism-associated deglycase gene. It is an antioxidative protein. Loss of DJ1 was shown to cause worsened lung injury upon LPS challenge. It is also cytoprotective in alveolar space during lung injury. We want to know if DJ1 is involved in airway allergic inflammation. To examine this, we used the overbooming-induced mouse model. We found that the DJ1 protein was increased in the lung after OVA. To know what cells in the lung contribute to the increase of DJ1, we did the single-cell ion sequencing on lungs isolated from control mice or OVA-treated mice. We observed that DJ1 was increased in club cells and in eosinophils, but decreased in other cells, including fibroblast cells, macrophages, T cells, NK cells, innate lymphoid cells. To investigate the role of DJ1 in airway allergic inflammation, we adopted DJ1 knockout mice. In absence of DJ1, leukocyte infiltration in the bronchial alveolar lavage fluid was largely diminished, as well as eosinophils. Interleukin 13, but not 5, was decreased in this case. Since goblet cell hyperplasia is a common feature in asthma, we'll look at the influence of DGA1 on goblet cell differentiation in the lung. In mice hosted under specific pathogen-free facility, goblet cells are rare in the lung, but can be induced by OVA. Goblet cell differentiation by club cells was inhibited when DGA1 was lost. Next, we look at the communication between club cells and eosinophils after OVA. By single-cell ion sequencing analysis, we found that club cell eosinophil interaction was decreased in absence of DGA1. Interestingly, alveolar epithelial cells interaction with other cells are promoted in absence of DGA1. We didn't follow on this because we look at the airways, we focus on the airways, but it would be interesting to follow on because distal airway disruption was also observed in severe asthma. We know that the lung epithelial cells, including club cells, can recruit eosinophils by producing chemokines during lung inflammation. But how do eosinophils impact club cell functions? We use the individual organoid cultures. So first, we isolate eosinophils and club cells from mouse lung. And then we put them together in organoid cultures. In a couple of days, individual club cells grow into colonies. Based on the colony size and forming efficiency, we can tell the growth rate of club cells. We found that the colony size and the forming efficiency was reduced in presence of eosinophils, suggesting that the eosinophils inhibit the proliferation of club cells. To confirm this, we stained the colonies with the proliferating marker KR67 and found that the fraction of proliferating club cells over all club cells were reduced in presence of eosinophils. Such a regulation seems to be DGA1 independent, since there was no difference between the cultures with EOS and with DGA1 knockout EOS. Next, we examined the impact of eosinophils on goblet cell differentiation from club cells. To do so, we sorted eosinophils from OVA-treated mice. We did this because we can get as many as eosinophils in this way as we can use the untreated mice. Then we transplanted eosinophils into white-type untreated mice intratracheally. By day 5, as compared with the untreated group, we can see the goblet cell differentiation was promoted when EOS was transplanted intratracheally. If eosinophils was lack of DGA1, the goblet cell differentiation was reduced. So this data suggests that the DGA1 in eosinophils drives airway goblet cell differentiation. What about DGA1 in other cells? To answer this question, we instilled normal eosinophils to wild-type or DGA1 knockout mice. Interestingly, goblet cell differentiation was also reduced in recipient mice lack of DGA1. All right, what about club cells themselves? We established a transgenic mice with selective deletion of DJ1 in airway club cells. During over-induced allergic inflammation, goblet cell differentiation was inhibited when club cells was lack of DJ1. Together, these data demonstrate that DJ1 in eosinophils or club cells drive goblet cell differentiation. By pathway analysis, we found that the absence of DJ1 resulted in reduced arachidonic acid metabolism, especially towards the cystinoid leukotrienes. So this data suggests that the cystinoid leukotrienes may promote airway goblet cell differentiation. So we went on to examine this. In organoid cultures, addition of LTC4, LTD4, or LTE4 promote the goblet cell differentiation. As you can see, it's markers of the goblet cells. In vivo, if we delivered these cystinoid leukotrienes to the lungs intratracheally, we also see the increase of goblet cells in mice. However, cystinoid leukotrienes does not influence the proliferation of club cells as evidenced in organoid cultures. Let me summarize. DJ1 is increased in airway club cells and eosinophils during over-induced allergic inflammation in mouse. DJ1 mediates communication between club cells and eosinophils. Basically, DJ1 promotes the metabolism of arachidonic acid in eosinophils to generate cystinoid leukotrienes, which promote the differentiation from club cells into the goblet cells. Eosinophils also inhibit the proliferation of club cells. There are so many questions are interesting, but they need to be addressed in the future. For example, does DJ1 regulate eosinophil functions, for example, degranulation? Communication between eosinophils and airway epithelial progenitor cells is much more than this. What about others? Airway epithelial injury was observed in asthma. What is the stop signal when this injury was repaired? How many signals must be stopped to terminate eosinophilic asthma? This work was supported by the National Natural Science Foundation of China. This is my group. Quan Li led this project. Thank you so much.
Thank you, Dr. Chen. As we're waiting for questions in the Q&A box, I wanted to ask you, so what about in eosinophil deficient mice or models? Do you see some of the effects of, for instance, like this cis-leukotriene effects, even in the absence of eosinophils? Or would they still be sufficient?
This is a very good question, and we never examined that, but this is a good question. So, just some people claim that the eosinophils are important in the early stage of the eosinophilic asthmatic inflammation, trying to clear the allergens. But our work demonstrated the persistency of eosinophils is not good. It damages the epithelial barrier. They cause a persistent damage to the barrier, causing the dramatic production of inflammatory cytokines. So, but that is a good question. yeah, if we, use the eosinophil knockout mice, whether we see the same phenotype, that's a good question. We don't know yet.
Okay, thank you. We have a question from Dr. Andrew Higham, a comment saying, great talk, thank you. Do you know what the impact of cigarette smoking is on DJ1 expression and or function?
Not specifically. So DJ1 is known for its anti-oxidative protein, but in our case, it seems to be pro-inflammatory cytokine protein. So it's actually surprising when we got this data. So for the smoke injury, I don't know yet whether they have a similar phenotype as we saw in the asthmatic pathology.
Thank you. So we have another question. Are you investigating other shared eosinophil and epithelial cell-derived factors that contribute to other characteristics of asthma, such as, for instance, remodeling?
No, no. Our lab is focusing on the epithelial injury and repair, by specifically the function of the epithelial stem progenitor cells. And but I do think the interaction between epithelial progenitor, stem progenitor cells and other immune cells is also critical, either for the development of allergy or actually the control of the allergic inflammation. So we know the epithelial cells are the first or the original source of cytokines to recruit the immune cells, including eosinophils. But I'm sure the eosinophils themselves may also have some roles to recruiting the other immune cells, including eosinophils as well. I think the communication here is very complicated, and for the type 2 asthma, we think the eosinophils and the epithelials are the two major players in these games. So we're trying to get some little bit data on this, but the definitely is interesting. That is a good question. It's a good question. There's a lot of issues not answered yet.
Okay, thank you. Another question from Dr. Ackerman. Anything known about the mechanism of action of DJ1 in these functions, particularly in terms of its enzymatic activity and airway remodeling?
Right, that's a very good question. That means what is the target of DJ1 in this scenario? Yeah, that's a good question. So I think this definitely the question is going to be answered. Is specifically important to tell the target of the DJ1 in the airway, either in the stem cells or the eosinophils, because the model we use here is the knockout of the DJ1 in all cells in the lung, and so the knowledge we know about DJ1 is they can eliminate the oxidative stress, the species, but the target of this protein, I think we didn't go very down to this biochemical actions. Yeah, we didn't go that deep. Sorry for that. That's definitely a very good question.
All right, well, thank you very much for your presentation and for answering the questions to the group and your interesting work. I would like to move on to our next presenter now. Our last presentation for today is Dr. Nair, who is a professor at McMaster University. His research focuses on developing and applying novel sputum biomarkers and bioimaging techniques aiming to treat patients with complex airway diseases such as severe asthma, COPD, EGPA, and other eosinophilic lung diseases. So he will be talking to us today about the complex interplay between eosinophils and mucus in severe asthma. Take it away, please.
Right. Can you hear me?
Yes.
Yes, right. Thank you very much to the International Eosinophil Society for inviting me to join this panel. And it's quite an honor to follow Professor Bill Busse, who has already shared with us the importance of targeting eosinophils and the IL-5 pathway. What I would like to do in the next 20-25 minutes is to discuss the possible complex interplay between eosinophils and mucus, and question whether the benefits of targeting of the improvements of observed in asthma by using biologics to target the various Th2 pathways, particularly the eosinophil-driven pathways, is solely by decreasing the eosinophil numbers and activity, or perhaps is there a unrecognized or underappreciated effect on clearing mucus, which is important, actually very important in clinical practice. I'd like to share with you evidence from certain clinical trials, two of them that we have just recently completed. We do not have all the data. Data is still being analyzed, but I hope it will give us some insight. These are my conflicts of interest. Two of the studies are investigator-initiated studies. One was supported by AstraZeneca and the other by Sanofi. But these were independent investigator-initiated studies. I'd like to pay tribute to pioneers who had questioned this before. Most of you would know these two scientists, leaders in our field, who are visionaries. My mentor, the late Professor Freddie Hargreave, and Dr. Harry Morrow-Brown. Here they are toasting to the eosinophil at a BSACI meeting in 2008. Harry Morrow-Brown, a few months before he died, sent me these slides by email. He used to look at wet smears of sputum and do quick stains right in his clinic to adjust treatment. He identified eosinophils in sputum to be relevant in patients with asthma. He also identified that the free granules in sputum were extremely relevant. The activity of the cationic proteins are extremely relevant. He also observed the Charcot-Leyden crystals, which had been described over 100 years ago, which we have forgotten until Dr. Bart Lambert's group have brought it back to the forefront. It's extremely relevant in driving mucus, as Emma Persson showed in her elegant publication in Science by directly upregulating MUC5. The importance of Kirschmann spirals in sputum have been forgotten. And last but not the least, he also observed that in sputum you could see mucus cusps. So all of this have been known. We tend to ignore this. 50 years ago, Harry Morrow-Brown took on the mighty British Medical Research Council and demonstrated that in those patients who have eosinophils in sputum, corticosteroids are extremely effective. And in those who do not have eosinophils in sputum, steroids are not effective. And this paved the way for inhaled corticosteroids to be used in patients with asthma. Now, steroids do reduce eosinophils. It could have an effect on mucus, the benefits, and it could have an effect on so many other pathways relevant in asthma. And therefore, we cannot really conclude that the effects of steroids are solely by reducing eosinophils. However, as we heard from Professor Busse, the advent and availability of directly targeting IL-5 with biologics such as mepolizumab, rosalizumab, and benralizumab that effectively reduces eosinophils have given us an opportunity to now assign possibly a causal role to eosinophils and asthma. I've summarized all the anti-Th2 T2 biologics clinical trials in this slide. Now, all these studies selected patients based on raised blood eosinophils. All of them were effective. However, divergent pathways such as targeting IgE, targeting the IL-5 ligand, the IL-5 receptor, the IL-4 receptor, or alanamin TSLP all give comparable results. These studies were all, patients were recruited into these studies based on a raised blood eosinophil count. It's therefore difficult and almost impossible to conclude that the eosinophils are indeed contributing to the pathobiology. They might simply be a reflection of the burden of the T2 disease rather than contributing as effector cells to biology. And we cannot really conclude that the benefits are indeed by decreasing eosinophil counts in the blood or in the airway. On average, actually, there's no difference between the biologics, and this is not really precision medicine. We really cannot choose between these biologics in clinical practice based on blood eosinophil count. They tell us that all these biologics are effective. And therefore, we need to very critically examine the predictor response versus effector response. And I've used just one example of benralizumab to pay tribute to my late colleague, Mark Fitzgerald, who put this data together using the benralizumab pivotal clinical trials. And this applies for any anti-IL-5 biologics. On the x-axis, you have increasing blood eosinophil count, and on the y-axis, any treatment outcome relevant to asthma. In this instance, reduction in asthma exacerbation. And as you could see, at baseline, higher the blood eosinophil count, greater the treatment response. And this is consistent for any anti-T2 biologic. However, benralizumab, as we demonstrated in collaboration with my colleague, Dr. Omar Semi, decreases and almost completely wipes out eosinophils in the lumen in patients with severe prednisone-dependent asthma. So baseline eosinophilia is a predictor of treatment response in this instance, and it also suppresses eosinophils. If you look at another example, this time targeting TSLP in not OCS-dependent patients, but patients with severe asthma on high doses inhaled corticosteroid, once again, baseline eosinophil count is a predictor of treatment response, and greater the eosinophil number, greater the treatment response. And in the non-OCS dependent patients in a 3-month clinical trial compared to placebo, Chris Breitling's group demonstrated that tezepelumab also decreases the eosinophil numbers in the submucosa in bronchial biopsies compared to placebo. So here, again, baseline eosinophilia is a predictor of treatment response, and it seems to suppress eosinophils in moderate asthma. However, mind you, we do not have data in the prednisone-dependent asthma, and the phase 3 OCS trial was negative, and the second trial is being done. Now, if you look at dupilumab that targets the IL-4 receptor pathway, it's exactly the same message. At baseline, greater the eosinophil number, greater the treatment response. There's absolutely no doubt that the blood eosinophil count is a predictor of response to T2 biologics. But this unpublished clinical trial, very similar design to the previous tezepelumab clinical trial, 20 patients randomized to dupilumab or to placebo over a 3-month period, there is no statistically significant difference in the eosinophil numbers in the submucosa. However, what the investigators have reported on data that's available on clinicaltrials.gov is a significant reduction in the area of the submucosa staining either for PAS or for MUC5 gene, and a significant reduction in the exhaled nitric oxide, which is not surprising. So does it mean that the benefits of dupilumab is by decreasing mucus and not by decreasing eosinophils? In which case it's surprising, and this needs further clarification. So again, there is a divergence between the predictor and the effector response. As a matter of fact, eosinophils in blood can transiently increase in patients with dupilumab. Almost all patients have a transient increase in dupilumab. Very high increase is extremely rare, but it does happen in some patients. And currently, we do not have any method of investigating or identifying at baseline in which patients this is likely to happen. There have been a number of reasons, mechanisms postulated, including damming of the eosinophils in blood, preventing them from egressing by blocking some of the adhesion molecules, particularly the VLA4 adhesion molecule, and therefore preventing the egress of eosinophils from blood into tissue. Perhaps an endothelial microRNA1 could be inhibited, or it could be due to blockade of eotaxin, that the eosinophils could get trapped in blood. But whatever it is, we currently do not have evidence of targeting the IL-4 receptor pathway of decreasing eosinophils in the tissue. Now, could it be really by decreasing mucus? The contribution of mucus is again not new at all. Professor Donnell's extract from the textbook of pathology published in Oxford many years ago does clearly demonstrate the contribution of mucus in patients with asthma, plugging the airways, both in moderate and severe asthma and patients who unfortunately have died of acute severe asthma. Now, what drives mucus? We heard this very elegant talk from Dr. Chen of a direct effect, perhaps, of eosinophils contributing to the metaplasia. This is a cartoon that I've adapted from Lauren Korn's publication, which shows that the early signaling for this metaplasia of club cell to a goblet cell is derived from EGFR signaling, but later it is from the IL-4 receptor signaling, with a major contribution from IL-13 that activates STAT6, that activates the MUC5 AC gene. Now, STAT6 also activates inducible nitric oxide synthase and elevates nitric oxide. Now, IL-4 and STAT6 are not the only signals that could activate inducible nitric oxide synthase, but it is reasonable that in the absence of any eosinophilia, if you have a high exhaled nitric oxide, or even better, an increase in exhaled nitric oxide despite controlling the eosinophilia, it's reasonable to assume that there might be residual IL-4 signaling that Ian Paywood's group and a number of other groups, including the Severe Asthma Network in the UK, have demonstrated. Now, we know that the eosinophil-derived IL-13 could drive mucus. Now, could the mucus contribute to eosinophilia? There is some elegant data, this from John Fahey's group, that demonstrates on the y-axis here the ratio of 5B, MUC5B, to MUC5AC in 3 groups of patients: healthy, asthmatics when they are stable, and asthmatics when they exacerbate. And as you could see, the ratio decreases during an exacerbation. In other words, MUC5B decreases and MUC5AC increases. In those patients who have less MUC5B, there is greater eosinophils in the lumen. This seems to suggest that there might be a reverse directional influence of MUC5 on eosinophils. And how does that happen? I do not have the exact precise answer, but there is evidence from Bruce Bochner, who is on this panel, and perhaps he could illuminate this very elegant study that looked at conditional knockout MUC5 mice and had IL-13 instilled into the airway. The eosinophils increased in the airway. Eosinophils were persisting for longer, and the mechanism postulated was increased survival or prevention of apoptosis, as demonstrated by the increased annexin stain in the control and decrease annexin stain in those patients who had those mice who had the MUC5 knockout. So essentially what this suggests is that there is a bidirectional role with the eosinophil-derived IL-13 perhaps contributing to the metaplasia and goblet cell hyperplasia and mucus secretion, and the mucus composition with more of the MUC5B contributing to the persistence of the eosinophilia. Now, this has never been tested in humans. How does this happen? What exactly is the composition of the mucus that leads to the eosinophils dying? We do not know. Is there any particular composition, any particular polysaccharide or the glycan that could potentially activate sialic acid and lead to apoptosis of the eosinophil needs to be investigated. But in clinical practice, how could mucus be identified? John Fahey and Elena Danikin suggested a method which was to quantify mucus using airway CT scans and come up with a mucus score. There are 20 bronchopulmonary segments. If each segment has at least one score, he would assign a score of 20. And if no segment has mucus in it, the score would be 0, with score of 5 or greater being considered clinically relevant. Helena Daniken demonstrated that those patients who have high mucus score here in orange have lower FEV1, greater airflow obstruction, and those patients also have greater levels of eosinophils in sputum. Do these patients have greater IL-4, IL-13 activity in sputum? They do. We and others have demonstrated using the same score that Helena Daniken utilized that those patients who have a higher CT mucus score have higher sputum IL-4, IL-13, and exhale nitric oxide that goes in hand with the increased IL-4, IL-13 activity. In clinical practice, how could this be identified? What we think we could use the exhale nitric oxide measurement, particularly in patients who have been treated with an anti-IL-5 after normalizing the eosinophil. If the exhaled NO does not change or even increases after controlling the eosinophilia, those patients are more likely to have greater levels of IL-4 and IL-13 in their sputum. Or if the exhaled nitric oxide level does not come down to normal or remains over 40 parts per billion, those patients are likely to have greater IL-4 and IL-13 in sputum. So this is possibly a method to identify residual IL-4 and IL-13. Of course, it is not just the IL-4 and IL-13 that could drive the exhaled nitric oxide. We clearly have two patient population, a population of patients who may have mucus and exhaled nitric oxide persisting after the eosinophilia is controlled, who have raised IL-4 and IL-13, suggesting that those two cytokines might be driving that process, but also a second group of patients with raised exhaled nitric oxide and mucus who do not have raised IL-4 and IL-13. And our preliminary data seems to suggest that it is the autoimmune process that might be driving this, with perhaps a contribution from the inflammasome. Manali Mukherjee, my colleague, is investigating this, and we do not currently have a definite answer, but we hope analysis of the two clinical trials that we have completed recently will give us some insights. Now, how do we tease apart the relative contribution of mucus versus the eosinophil? Do they go hand in hand? Is one more important than the other? Again, this longitudinal data from the Severe Asthma Research Program in the US, published by John Fahey's group, suggests that there is a very good correlation between the change in mucus score and the change in eosinophils in sputum. Sarah Svenigsen, my colleague, investigating this using CT mucus score and ventilation scans using a hyperpolarized xenon or helium MRI, has demonstrated that when the eosinophilia is controlled, the mucus score disappears in almost 2/3 of patients, suggesting that the eosinophil-derived proteins or the eosinophils directly, as we heard, might be contributing to the mucus occlusion of the airway. However, in 1/3 of patients, it would persist. But how could really we tease out the contribution? Here are two clinical trials in severe OCS-dependent patients. These are not head-to-head comparisons, although I put them on the same slide. Benralizumab in the OCS-dependent patients was very effective in suppressing eosinophils, as we have demonstrated, and prednisone sparing and decreasing exacerbations. Dupilumab, in a similar population of patients, also had a similar magnitude of treatment effect. Mind you, again, this is not direct head-to-head comparison, but as we heard, and as I demonstrated from the unpublished clinical trial data on NIH, on the clinicaltrials.gov, dupilumab did not effectively decrease eosinophils, but decrease mucus. So how could we reconcile this data? One treatment significantly decreases eosinophils, the other does not seem to decrease eosinophils, but decrease mucus, but they seem to have the same magnitude of treatment effects, although there's no statistical comparison between those. So what is more important, targeting the eosinophil or targeting the mucus? Or when you target the eosinophil, does the mucus goes away? But then if we clear the mucus and if the eosinophils persist, as the dupilumab data would suggest, is mucus more important than clearing the eosinophils in the airway? Now, anti-IL-5 biologics do decrease mucus, but they do not clear mucus. This is data that my colleague Carmen Venegas, working with Sarah Svenigsen, looked at in our patients on biologics who had CT mucus scoring. About 30% patients on mepolizumab of the approved dose of 100 milligram have persisting mucus. About 36% of patients on rozilizumab also have persisting mucus, and about 22 to 25% of patients on benralizumab that we know can effectively clear eosinophil would still have persisting mucus. Now, we just completed this clinical trial that my colleague Manali Mukherjee presented at the ERS that shows that benralizumab is perhaps the most effective in clearing eosinophils, completely normalizing eosinophils. We selected patients who had persisting eosinophils in their sputum despite being treated with rozilizumab or the 100 milligram mepolizumab, and then provided them 2 months of placebo or 6 months of benralizumab, and they completely suppressed their eosinophils. However, it doesn't mean that they all got better. 6 or 7 of these patients continue to have an ACQ-5 over what we would consider as completely well-controlled asthma, and they have raised exhale nitric oxide, suggesting that this might be due to mucus or an IL-4, IL-13 pathway that's persisting despite targeting the IL-5 pathway. Benralizumab does clear mucus. This is data that Sarah Svenigsen, along with Grace Paraga in London, published, looking at 2 representative patients here and their ventilation scans. On the upper panel is a patient who had ventilation defects with high mucus score of greater than 5. Benralizumab completely normalized the mucus score and ventilation. But on the lower panel, the ventilation defects persisted despite clearing the eosinophil, suggesting that there is persisting mucus. Now, what does dupilumab do? Does dupilumab actually clear mucus? Does it clear eosinophil? The data from the unpublished clinicaltrials.gov seems to suggest it does not. So we undertook a clinical trial of taking patients who have airway mucus and who have eosinophils in their airway and randomizing them to dupilumab or placebo. 12 patients received the active drug, 12 patients received placebo. This is preliminary analysis of anti-IL-5 and mucus. And dupilumab and mucus. And what we showed, in contrast to the tissue eosinophilia, is that dupilumab does decrease sputum eosinophils in patients with moderate to severe asthma compared to placebo. So this is no surprise. So that sort of takes care of our mystery that the benefits are not just by reducing mucus, it does decrease eosinophils and consequently decreases mucus. As you could see, there was 1 patient in whom the eosinophils went up, both in blood and in sputum. This does happen with dupilumab for reasons that we do not quite understand at baseline. There are some patients who have breakthrough eosinophilia with the numbers increasing to very high levels in peripheral blood and in the airway. And in those patients who receive dupilumab, the ventilation also significantly improves by clearing the mucus and the eosinophils. There were 3 patients in whom the ventilation was not completely normalized. It's not because the mucus was driven by an IL-4, IL-13 pathway, but that ventilation defects, we believe, is because of infections. 2 patients had infections and another patient had fixed airflow obstruction remodeling, leading to the ventilation defects. Dupilumab's benefits could also be due to clearing both eosinophils and the mucus, as this data that Chris Breitling presented at the ERS suggests that it could decrease mucus. So to summarize, there is this complex interplay between eosinophils and mucus. Both have to be taken into consideration. IL-5, as we heard, could bring eosinophils out of circulation into the airway, into the lumen, activate them, release their products. IL-13 could release thiocyanate and induce goblet cell hyperplasia. The mucus could become oxidized and more viscous with the interaction of the thiocyanate and the eosinophil peroxidase, leading to cross-linking and plugging the airway. One has to target in severe asthmatics with thick mucus, both the IL-5 pathway and perhaps the IL-13 pathway. And it remains to be seen if there is a feedback between MUC5 mucus and eosinophils by making the eosinophils survive longer. And we hope to have the answer by studying mucus composition in the 2 clinical trials that we did of targeting the IL-5 pathway and the IL-4 receptor pathway. How would we actually put this in practice in clinical medicine? This is a 46-year-old patient with severe uncontrolled asthma requiring high doses of treatment with oral corticosteroid, significant hyperresponsiveness with a very high exhaled nitric oxide, intense airway eosinophilia and degranulation and raised blood eosinophil count, suggesting both IL-5 and IL-4 receptor signaling with significant airway mucus and autoimmune responses in the airway. The patient's eosinophilia and asthma were not controlled with the approved 100 milligram dose of mepolizumab, and therefore the patient was switched to a higher concentration of neutralizing antibody rozilizumab that enabled prednisone reduction, but not total control of asthma. Exhaled nitric oxide remained over 60, as I demonstrated, with the suggestion that there's residual IL-13 activity, and therefore we added dupilumab onto the anti-IL-5 for total asthma control, which was reflected also in a ventilation scan with complete normalization of ventilation. And this is our current practice now of dual biologics in such patients who have got persisting mucus. Despite controlling anti-IL-5, we use dual biologics, and this is our experience that we have just published in JACI in practice of sequentially following guided by cytokine measurements. This is a summary cartoon of what I have discussed in choosing the primary target. If the predominant contributor to asthma is luminal obstruction with eosinophils, the primary treatment would be perhaps an anti-IL-5 or anti-IL-5 receptor. However, if the primary contributor to luminal obstruction is mucus, even if there are some eosinophils persisting in the lumen, perhaps an anti-IL-4 could be the primary target, as the anti-IL-4 blockade could also reduce eosinophils. And perhaps by clearing mucus, there could be an indirect effect on eosinophils as well. If the patient has eosinophils and mucus persisting and thick mucus persisting, perhaps those patients, fortunately very few in clinical practice, might need combined blockade, and perhaps we might need bispecific biologics to treat such patients. The most complex patients are those who have eosinophils and mucus, who also have immune complexes and who have recurrent airway infections in which the neutrophils and the neutrophil extracellular traps and the immune complexes could be driving mucus, for which we currently do not have any effective treatment. So I'll conclude with these take-home messages that mucus is an important contributor to airflow obstruction, and it's underappreciated, and we need to pay more attention to that in clinical practice. Eosinophils are associated with mucus, and we heard from Dr. Chen a very elegant talk on a direct mechanism by which eosinophils might contribute to mucus metaplasia, goblet cell metaplasia. Eosinophil-derived IL-13, IL-4 traps, and the Charcot-Leyden crystals that I did not talk about might contribute to mucus. But there could also be non-eosinophil-derived IL-13 and other cytokines that would contribute to the mucus. When eosinophils are cleared, mucus is cleared in about 2/3 of patients with severe asthma in clinical practice. Tezepelumab and dupilumab may decrease mucus score and eosinophils. I've shown you preliminary data from the clinical trial that we have just completed. We'll have more analysis soon, specifically of the mucus composition as well. Both eosinophils and mucus are important targets in severe asthma. And I'll conclude by saying that no asthma anti-inflammatory treatment that does not decrease luminal eosinophils have been shown to be very effective. And we thought dupilumab might be an exception, but it is not. Thank you very much. I'll be happy to take any questions.
Well, thank you very much for this excellent presentation. I will start off with a few questions. Are there clinical signs where mucus may be more important, and are they bigger producers?
I do not have the answer to this, but what John Fahy's group has demonstrated in patients with COPD is that chronic coughing and sputum production is not directly a reflection of mucus impaction in the airway. Patients may have mucus impaction even if they are not, if they do not expectorate large quantities of sputum. What he demonstrated in COPD is that the chronic bronchitic or expectoration component of the St. George's Respiratory Questionnaire or the chronic bronchitic component of the WHO the mucus questionnaires were not predictors of mucus impaction identified by CT scores. So currently, we may not have a very clinical method of identifying who might have a lot of mucus. The best that we have got is to use CT scans in patients with severe asthma, look at them carefully and identify mucus plugging. I think that's a skill that we as respiratory physicians should develop rather than always depending on our radiology colleagues.
Okay, thank you. Another question, is there any useful information from trials of dexpramipexole?
No, we do not have any data related to mucus production or airway eosinophil kinetics from dexpramipexole. As you know, all we know, once again, is that the presence of eosinophils at baseline in blood is a predictor of response to dexpramipexole. We do not know how the drug works. It's thought to be by arresting eosinophil differentiation. It's not by a direct effect on the bone marrow, but whether it has an effect on mucus, we do not know. But essentially what I'm getting at is in any intervention that decreases the eosinophil numbers and activity would indirectly have an effect on mucus in about 2/3 of patients if that intervention is effective. In 1/3 of patients, the mucus might persist even after clearing the eosinophils through signaling mechanisms other than through the eosinophil.
Thank you. There's a question if there are any results in patients treated with tezepelumab and benralizumab. Is this as useful as dupilumab and benra?
So thank you, Professor Gleich. I do not have any data on mucus composition of any of these interventions. No, to the best of my knowledge, no one has published or I looked carefully at the mucus composition. The only published data or abstract data is what I showed with tezepelumab that was presented by Chris Breitling's group at the ERS, quantifying mucus in CT. Again, this was not the same method that they used as John Fahey has published. This was a machine learning algorithm that Vida has come up with, and I haven't seen the data in full. So short answer to your question, no, we do not have any data of any biologic on mucus composition. Hopefully in the next few months, we'll have data, some data on the mucus composition from our 2 clinical trials using benralizumab and dupilumab.
Thank you. There is a question on the mechanism. So could you speculate on what you think the mechanism of release of eosinophil-derived IL-13 might be in severe asthma? Is it cytolysis or something more precise, such as piecemeal degranulation?
I do not know, Praveen. I do not know the mechanism by which IL-13 is released from the eosinophil. There are more eminent eosinophil biologists in the group who might know. I just know that the eosinophils do secrete IL-13. I do not know the precise mechanism. Sorry. Sorry, Bill had a question.
Yeah, thank you so much. That was a wonderful presentation, and it really underscores the tremendous complexity of the processes. And this is sort of following up Reem's question. In John Fahey's paradigm, it's got eosinophils are activated, and that changes the rheology of the sputum. What activates the eosinophil in the airway to release eosinophil peroxidase? Do we know that at the present time? And what mechanisms can bring this about? Because right now it's sort of cell associated rather than necessarily activation process.
very relevant question. We do not know. I do not know. Perhaps people have studied cytolysis, Paige Lacey and others. Professor Gleich might know. He has studied the release of eosinophil-derived neurotoxin, but I do not know what precisely releases EPX, or whether there's a preferential signaling pathway that releases EPX or more. I do not believe there is. I think it's a general process. It's not specific to any one of the cationic proteins, but we do know that the EPX does cause not only the tenacity, to contribute to the tenacity of mucus, but as my colleague Manali Mukherjee has demonstrated, that the autoimmune responses directed against the EPX in patients who also have recurrent airway infections and lymphopenia, which is a reflection of the loss of immune tolerance, significantly contributes to the mucus production. So the peroxidase is extremely relevant in terms of not just contributing to the tenacity of mucus, but the precise process, whether we can block the peroxidase release. I just do not know. I do not know. There could be someone in the audience who could perhaps contribute. We have just completed and submitted for publication our point of care method of measuring EPX, 2 different strategies. Finally, we got it working, and the manuscripts are under review.
Thank you. We have just maybe half a minute left. So I was gonna read a comment from Dr. Bachner. I'm sorry, this just escaped on me. The box, sorry. Where did they go?
Yes, so I can actually see that.
If you don't mind, yeah, I can't find it. The box.
So he, Bruce is the most knowledgeable in this, but he does comment that the primary airway pro-apoptotic ligand for Siglec-F and the eosinophils are the glycans displayed on MUC5B, and in humans, keratan sulfate is the primary ligand for Siglec-8. But surprisingly, in human upper and lower airways, a keratan sulfate ligand for Siglec-8 is carried on DMBT1 and not MUC5B. Why this occurs and how this is regulated remains unknown. So essentially, it's a very interesting suggestion. Thank you, Bruce. I took your suggestion, and what we are hoping to do in our studies are glycomics of sputum after intervention with biologics, different biologics, one that would directly target MUC5 and another that might indirectly target MUC5 by decreasing eosinophils, and see what happens to the mucin composition. The interesting speculation might be that in patients, in humans, all of them may not have the same composition, and some patients may have more keratan sulfate than others, and therefore those patients might have a greater effect with an anti-IL-13 than others. And this is just not tested, for which we might need to do comprehensive glycomic profiling in sputum in patients with a lot of mucus plugging.
Thank you very much, Dr. Nair, and thank you to all of the presenters. I will turn it back to Florence.
Thank you, Nives. And I would like to begin by thanking all of the prestigious faculty and our moderator for the wonderful presentations we heard today. Very, very high quality, very intriguing findings also that just show how much is yet to be learned in this complex disease, which is asthma. And on the next slide, I would like to once again thank our sponsors. So Regeneron is actually our only platinum level sponsor on our corporate advisory council. And so really would want to extend a very, very warm thanks for this support, because it's essential in continuing these webinars and retaining interest for the society and until our next in-person meeting. Next slide, please. So the future webinar, the next webinar is going to be held by the trainees. It's going to happen on November 16th. So this is not the last Wednesday of the month, as would usually be the case. This is November 16th. Our trainee representatives are currently polling trainees to decide which topics will be covered. This is going to be a webinar on methodology in eosinophil research. So if there are any trainees that are participating in this webinar today, I really encourage you to contact Eva Knuples or Kyo Son, who are involved in pulling together the different topics for this webinar. Next slide, please. And as I mentioned, our next symposium is being organized. We have now settled the dates and the venue. It will happen next July from the 11th to the 15th in the very, very nice David Braley Center, which is shown here, in very, very close collaboration and actually being steered by our colleagues from McMaster University in Hamilton, Canada. And they're really finalizing a wonderful scientific program with invitations for speakers, which will be going out very, very shortly from now. So I encourage you to visit our website on a regular basis to have more information about this symposium, but you can already save the date, which is shown here. Next slide, please. You can also follow us on social media. You can see here the different links that can be followed. Next slide. And if you want to learn more about our program, about our symposium, you can write an email to the Society, but you can also visit the website. And once again, here are the different links to do this. I thank you all once again very much for attending also this webinar. It's been very, very interesting discussions that we've had, and I look forward to seeing you again in November.